You're listening to Streetside, the Street Medicine Institute Student Coalition podcast.
Hello, this is Michael Brennan, to be your guest host today on Streetside. This is the official Street Medicine Institute Student Coalition podcast, and we're so glad you've joined us. Today I have the pleasure of interviewing Kate Pocock from Los Angeles, California. Kate, welcome to the show.
Thank you for having me.
Well, it's great to have you, and please introduce yourself to the audience.
Sure. So, as you said, my name is Kate Pocock. I am a physician assistant with USC Street Medicine. So I practice in Boyle Heights, and along with that, I also get a chance to work with the workforce development and education arm of our program. So that gives me an opportunity to do lots of education around the state of California as well as across the country, and then also do a little bit of research. And in my free time, I'm getting a doctorate in public health and health policy, in healthcare management and leadership. So getting to spend a lot of time bringing all of that framework to the street medicine context and having a ton of fun with it.
Wow, that's a lot. Tell me about your educational journey. Where did you start and how did you get to where you are?
Yeah, I'm sort of one of those classic cases of folks who really had lots of different journeys, and all of it brought me here today, which is super fun. But I started out getting my undergraduate degree in environmental earth science at Berkeley, and really thought I'd spend my entire life modeling climate for NOAA and doing things like that. But through lots of different changes, ended up getting more onto the public health side of things. Went down to Australia to get a PhD in tropical medicine as it relates to vector diseases. And through that process, decided that a clinical degree would really benefit me quite a bit if I wanted to feel like I had a strong context in public health. So dropped out of that, headed over to Duke University, where I got my degree as a physician assistant. And I was really lucky. I got to do an underserved scholarship program while I was there, spending most of my time getting to take care of folks in rural areas around North Carolina. And so that really set sort of the tone for my plans for my career. When I left, I sort of set this uncharted territory of I want to go serve every low-income population around the country so that I can see what's tough for my patients, what's tough for me, what's tough about the system. So I did. So I set out locumzine all around, and it eventually landed me on the Navajo Nation in Arizona, where I fell madly in love with my patient population and my peers and the hospital. And so I settled down there for 5 years. And then shortly before the COVID-19 pandemic, I moved over to the White River, or to the White Mountain Apache Reservation over in Fort Apache, and started to take care of folks there, both in the ER, and then got pulled sort of out into the community as we were doing a big COVID response that was much more focused on that sort of community approach. Began to accidentally do street medicine, like very, very unstructured, which I think is how a lot of folks get into street medicine. And through that decided, it'd be really fun to see what this looks like in a structured environment. So I called Brett Feldman at USC and I said, hey, can I just come shadow? And he said, yeah, absolutely. So I came out, had the best time ever with the team. And at the end of it, Brett said, so by the way, we kind of have a job. So, at the time it was actually a really good decision for me and my family. And so we came out to LA, and now I've been with USC for 2 years, and it has been the fastest 2 years ever, because it's just been so much fun. So
I love your use of the word fun.
Mm-hmm.
That's awesome.
Yep.
And tell us about Los Angeles and homelessness and street medicine. What's it look like? We hear about the huge numbers, mm-hmm. but what does it look like from your vantage point?
Yeah, I think that one of the things that a lot of people, especially who are in homelessness services in LA, can feel a very strong sense of being overwhelmed, which is why I think we're really lucky to be in street medicine, because what we get is a chance to have a lens that's at the street level and also realize how impactful it is to do all of these programs, even on that small micro level. But very much so when you look up and you see just the sheer breadth of the situation where we are, it can sometimes feel like there's a lot more that needs to be done. So I am just really grateful to get to be a part of the community that's doing our best to try to see what we can do. And I think I heard a really great a really great thing from somebody at this conference, which was essentially start with 1, it'll turn into 10, it'll turn into 100. And I think if we can keep that mindset and just remind ourselves how valuable that is, it will take us really far.
I would imagine you see a lot of wounds, infections, abscesses in your work. Can you speak to that?
Yeah, it's probably one of the top things I think that we take care of. The other really interesting thing about wounds too is it tends to be one of the major things that folks will wave us down for, or that we can outreach, because it's something we can see. I can't look at you and see your diabetes or see your hypertension, but I can look and say, hey, can I help you with that? And so it really is one of those sort of low barrier ways to connect with a patient. And I love it. I think it's really fantastic. I got really lucky in my time in the ER for those 7 years. What I really did was I asked my nurses to teach me as much as possible about wound care, because in clinical education, we don't get a ton of wound care in PA school, or I've heard a lot from folks in med school and NPs. Well, NP is a little different because the nurses tend to sort of have that background. But I tried my best to learn as much as I possibly could about wound care, and I'm incredibly grateful that I did, because it's really important to understand all of the different bandages we have available, but also what we should not be using, right? Because first and foremost is do no harm. So we have to just really contextualize all of our wound care plans, specifically to street medicine, but also to all of our individual patients. And I think it looks really different than brick and mortar wound care.
We're going to talk more about that, but I have to offer a comment first from my own experience in street medicine, that the water or the sandwiches or the socks become our calling card, but also the Band-Aids.
Yes.
That wound that has been there for weeks for the patient and isn't going away, that we can dress. And sometimes we do that even off the record. We just, here's some antibiotic ointment and a Band-Aid for your finger. And then we build that rapport. And the next time we come around, we can go deeper, further, broader into their healthcare.
Exactly.
So what kinds of things are you seeing?
So I will speak to sort of that global or that national perspective. We're not seeing as much xylazine as I think the East Coast is seeing. And so that is something that hasn't made its way to us, because I think, perspective is really important based on where you are in the United States. So I see a little bit of everything. Of course, I see those chronic venous stasis ulcers. Those are something that are really prevalent. We see lots of wound care or of wound issues secondary to folks who have lots of exposure to the elements. So if I have somebody with trench foot that goes untreated, those are some of the more common things. Also, inappropriate shoes that are just giving that chronic friction rub, especially in a diabetic, and now all of a sudden they have this really unhealed wound. We certainly see trauma that has resulted in some wounds that are having a difficult time healing. And then certainly quite a bit of abscesses. And so I definitely see that. And that's, secondary to lots of trauma that can happen to the skin, whether that is from an IV drug user or whether that's just from somebody who is putting a hand into a recycling bin to pick out a can. And there is now a really big wound that needs a lot of our help.
I'm curious, are you using butterfly ultrasound on the streets for abscesses to check for fluctuants and fluid? Is that something you're doing?
So that's a really good question. The answer is yes, no. Yes, we are, but we are still sort of formalizing the ultrasound for all of the folks on our team. But as somebody with an ER background who had an ultrasound at my hand all the time for 7 years, well, not for 7 years, but certainly in the last few years, I have become very accustomed to wanting ultrasound all the time. Also, my folks love it, right? Like patients just think it's great that you get to sort of show them like, hey, this is what a fluid pocket. Yeah, right. This is your fluid pocket. So do I? Yes, it's when my medical director is able to, come out with me or hand it to me at times. Yeah, right. But definitely using it.
So the standard incision and drainage of an abscess is with an 11 blade scalpel or 15 blade, and open it up and break up the loculations, the pus pockets inside. And that's what we've learned to do in the emergency room. One of the PAs that I met 2 years ago, I'm going to mention him by name, Joel Hunt from Fort Worth, Texas, encouraged me to use a 4 millimeter punch biopsy for smaller abscesses because it keeps it open, allows it to drain, and it's been very effective in my practice. Is that something you do?
So I'm going to take it one step further. I think the punch biopsies approach is fantastic. I also think A typical, incision drainage with 11 blade is great. But one of the practices that really was taking off in my ER when I was departing was loop drains. Have you spent any time with loop drains?
No, don't know what those are.
So this is something that the ER world is really starting to get behind. And essentially what it is it's two small incisions on either side of the abscess. And I'll get into a second where you can kind of get yourself in trouble there. But it's two small incisions, and you take a small vessel loop drain, which are incredibly cheap and super easy, and you feed it underneath and you tie it off on top. And so what it does is it gives a little handle for flushing. It also lets folks, it is very easy for them to remove themselves. So if somebody were to just tie it off and pull it, they'll be just fine. And so this is something that we were doing pretty like universally in our emergency department and having fantastic outcomes. Patient satisfaction was really high with them, and decreased rates of needing further intervention was super low. So I got really into it. It has been hard to get my hands on small vessel loops for the street. So that's been sort of my smaller issue here and there. And then the other key thing to know, and this kind of comes back to the ultrasound, is making sure that you don't make your incisions too far that you can't actually feed it underneath. And so one time in the ER, I did that and had to ultrasound myself to connect, the two sides. So definitely, it's not a perfect science, but it's one where I've actually had significant, like I say, the patient satisfaction and also just the outcomes have been really helpful. So I haven't found a ton of street medicine folks that are doing it yet, but I have found a few, most of them with the ER background. Those are kind of the folks that are interested in it.
I've seen them from the ED.
Yes. Yeah.
I've seen them come out back on the street.
Yeah.
I remove them.
Mm-hmm. Yeah. So I'm trying to sort of really kind of shop this idea around a little bit more and see what other folks think, because I really do like it. And then what I'll do is I'll leave folks with a water bottle, and I'll just take a 16 gauge, poke a hole in the top, and now they've got a high pressure flush. Oh. So then they can just pull it up flush, and it's really
brilliant.
great. Yeah. So
that's appropriate technology.
Yeah, exactly. Yeah. No, it's really great. So that is one. But again, like back to your question, I think the punches are great as well. Yeah, I've seen really good outcomes with those too.
Yeah, I really, it's less painful for the patient as well. So let me ask about your favorite wound care dressings. What do you use?
Yeah, so that's a really fantastic question. And I have two off the top of my head that I pretty much talk about with everybody. In terms of, and this isn't a dressing, although it can be impregnated into it, but Medihoney is just, I carry a pouch which has Narcan, eye protection, and Medihoney. Those are like my three sort of go-tos. And you can get bandages impregnated in Medihoney, which is really, really nice. So that's probably one of my top favorites. And then also I do admit that I come from sort of a background where we didn't have a ton of bandages. So I am a huge fan of just your simple things.
Such as ACE wraps?
ACE wraps. I love a good Curlix. I think that's something that I'm really happy to sort of give out to folks. Although, of course, talking about heat and bulk bandages can be really complicated for some folks. But just the non-adherent bandages, I really like the opportunity to leave patients with their own supplies. And so this really comes back to this like do no harm concept, right? And so one of the things that I love and appreciate about the patients we get to serve is that they are very willing to share their supplies with others. So I will not leave something like a calcium alginate or something where it could potentially do harm on a different wound. And so I really love the opportunity to just leave these very simple supplies where even if it didn't get to my patient, if it gets diverted to somebody else, it's going to be fine. And so I do like to do that quite a bit, especially if I can sort of, if somebody has identified themselves as someone who's excited to sort of do their own wound care, a simple approach is best for that. And so I really like to sort of stick to some of those. And I love it. We have a wound care nurse in California who does a lecture called Wound Care from the Dollar Store. And I just think that's brilliant. Like it's fantastic. So those are kind of some of my favorites. And then of course, I love a good foam. I love a good alginate for all of the reasons. But I think more commonly than not, if I'm reaching into my bag, I'm pulling out Medihoney or I'm just pulling out my simple things.
Yeah, that's great. And you made me think of two things. One is when we do this wound care on the street, I often like to give patients choices.
Yes.
right? So, we need to do this for your wound, but we can wrap it with Curlex, Coban, or an ACE wrap. Which do you choose?
Yes.
And just to give some agency and autonomy to folks. And we've also identified people that are the EMTs of the community. They're not EMTs. They're just other unhoused folks, but they take care of everyone else. So I load them up a little bit, like, oh, here's some extra antibiotic ointment and Band-Aids. And that leads me to a question. What do you think about antibiotic ointment, your Polysporin, Neosporin?
Yeah, I mean, I think that is a tricky question, right? Data used to support it. Data now is a little bit mixed. We have mupirocin in our bag, so I'm pretty excited to get to pull things like that.
Some of our listeners may not be clinicians. So what's mupirocin?
Yeah, so mupirocin is a topical antibiotic ointment that is a prescription, but has really great effects against MRSA, which is one of the reasons why I'm a big fan of getting to pull it out. And so it's also just very similar in its application as what we're talking about, like triple antibiotic, and it comes out in a way that's pretty viscous, so it's not uncomfortable for patients, super easy for them to administer to themselves, and it also can be, I've never experienced anybody who say it burns or anything like that, like some of the other prescription stuff that we use, and so this is something we recently got on our formulary. So before I was using things like bacitracin pretty readily, and I still use it. Like I think that is something that has a lot of value. But I'm also paying attention a lot to the literature that's coming out that is more specific to the etiology of the wound, because we do have lots of folks with burns and things like that, and it's not just from heating sources, it's also from cooking and doing that kind of stuff. So I really like to make sure I understand what caused this wound, and that's going to probably influence some of my prescribing habits a little bit, or some of what I'm pulling from the bag.
Do you carry Silvadene?
We don't, and I really wish we did.
The literature and the practice coming out of Philadelphia, where they're dealing with a lot of xylazine wounds, is Silvadene rather than, you can use Metahoney, but Silvadene is their go-to.
Yeah.
Which, is as goes Philadelphia, goes the rest of the country.
Yeah, no, I have to say, any opportunity I have to learn from that Philadelphia group that's been doing this xylazine wound care for so long, I'm all ears for them. And I've just been really, really intrigued to hear that sort of less is more approach with these xylazine wounds. And I have to be honest, I'm not sure that I've seen one. I can't speak with, definitive nature, but my patients have access. We include xylazine test strips in our harm reduction, and none of my patients have had a positive yet. So I'm waiting for it. But yeah, no, I definitely think that it's really intriguing, and I suspect when we do start to see xylazine wounds that we'll put some Silvadene in for sure.
Yeah, great. Let's talk about antibiotics. You're seeing a patient with a pretty good abscess with surrounding cellulitis, soft tissue infection. What's your approach? What are you doing?
Yeah, so this is a really, really interesting topic, because I think antibiotic stewardship at that sort of global perspective is going to be a little different than the perspective that we have. So I know recently there's been lots of shifts to not doing dual therapy, not doing your Keflex Bactrim and things like that, but I will say I still do that. I think for the folks that we take care of, it's really, really important, because I have seen non-purulent MRSA, and I've seen some things that are a bit atypical. And so if I've got an abscess with surrounding cellulitis, first, if they consent to an IND or anything where I can get rid of some of that pus for them, first and foremost, that's what I'm going to do. And then, of course, culture everything. I think that some folks might think that you can't transfer a culture well or easily, but it is fine. My cultures come back great. Yeah. And you and I were kind of speaking about it, but I've really been sort of studying some of the culture results of our group all together. And there has been a lot of polymicrobial cultures with 2 or more what appear to be actually pathologic, issues. And so lots of co-infections with MRSA and group A strep, or one of those kinds of combos. And so I do think about that a lot when I'm prescribing, and I don't think that a solo agent necessarily is going to properly address the issues. So I'm still doing like a Keflex Spectrum or a Keflex Doxy. I don't touch clindamycin very often, and it's not because I don't love it, but it's purely because of the GI upset that impacts folks. So I've pulled it twice now in my time doing street medicine. Once was for a pregnant patient who was going inside and had a MRSA infection, and then the other one was for a patient who had just really, really severe cellulitis and wasn't willing to go inside. And I had talked to her, and she was willing to sort of accept the GI upset of it. But otherwise, I'm a big fan of Keflex Spectrum. Historically, it was Keflex Doxy, but again, I can kind of go into this. But I essentially decided that it was, we really needed some better targeted therapy. So I developed an enhanced antibiogram for our group, specifically to skin and soft tissue infections. And through that, was able to see that doxycycline versus MRSA in the patient population that we're serving was just terrible. So it was pretty practice changing for me, because really I thought, Keflex Doxy was just such a great combo, and we know how good Doxy is for some other things that we're treating. And so it just felt like a good choice. And now I've had to really kind of reel back that thought process and get back to that sort of Keflex Spectrum approach.
It's interesting, the geographic or regional differences that we're seeing increased Bactrim resistance with the MRSA, and where it's sensitive to the Doxy. And maybe because Bactrim is used, so that's our first line. And I'm curious as well, what dosing do you do on the Keflex?
I do 4 times a day. It's not great. I think like the key, it's so tricky. First of all, we pull from our bag. And so our bags are sort of preloaded with, with the medications that we already have dosed out. And I will say with that QID, for starters, I had to take Keflex myself 2 weeks ago. It was impossible. I missed doses left and right. I mean, I was 100% like the person that could not adhere to the medications. And so it's a little tricky though, because I think if we're sub-treating things, then that's also not great. So if I'm telling you BID, then we're still not doing well. So what I've started to do, I still don't know how much I am committed to this idea, but this is my current practice, is to say 4 times a day and hope for 3 or 2. Because if we can, shoot for the moon and get some of those stars, it might be pretty great. Yeah. But I'm still pretty mixed on this. I could be convinced of some other options.
Okay, so in Rochester, New York, our standard is Augmentin 875 twice a day with Bactrim double strength twice a day, both for 10 days. Do you use Augmentin at all? I
do sometimes. Of course, I use it for any of my animal bites or dental infections. That's going to be the first one that I pull. But yeah, I would say intermittently, but oftentimes it's after I've gotten a culture result back and I'm making a modification. Okay. If I see that it's going to be a really great choice and I don't have a penicillin allergy in front of me, then I will choose that one. But I can't say that it's the first one that I pull from the bag. But again, I'm hoping I have more data now to look at in terms of our culture results. And so if I were to find a trend where it looks like that would be a better option, I would very, very much be willing to try that, because I think that BID dosing is so much more doable for our folks. But I have a question for you. Augmentin and the GI can still not go great together.
Right.
What are you finding there?
Well, it can cause the diarrhea,
right,
which is a huge downside if you're unhoused and a rough sleeper. But my patients tend to get at least 7 days in.
Okay.
So we're still using it, and I'm not hearing a lot of complaints.
Okay.
Thank you for asking me a question. I'm going to reverse it back to you now. Stewardship of antibiotics. On the street, those of us who do street medicine are seeing a lot of infections. We're using a lot of antibiotics. Tell me about what does stewardship look like for you?
I think that is exactly something that I'm asking myself that right now. But I think that the best thing that we can do is start to work on targeted prescribing habits, but it has to be founded on data, right? And that's one thing that street medicine is really starting to get behind is, first of all, collecting data, which has not been something that's always easy for everybody. And then aggregating that data and driving the car that way. Because in LA County, we're actually, when I first started to explore this topic, I got really excited because our LA General Hospital puts out an antibiogram that is a county-wide antibiogram that has 80% of the hospitals submit data. So it felt really comprehensive, and I was like, great, this is awesome. Like, we should be using this to kind of target our prescribing habits. But then when I started to follow that, I realized that it really wasn't working specific to my patient population. So that's where I think my current soapbox is that we really need to start thinking about how do we make sure that our targeted prescribing is specific to the folks that we're taking care of. And that's going to be kind of more on that micro level. And so I think for me, antibiotic stewardship is, of course, along the similar lines of don't overprescribe, don't underprescribe, but also how do we really enhance our knowledge of what the pathogens are that are impacting the patients we're serving, and then what do we need to be using against that. From the street level view too, I think it's so much education for our patients on so many different levels. I think it's describing to them why it's so important that they finish these antibiotics, right? I think if you just say that, which is what most pharmacists say, don't forget to finish your antibiotics, then that's not enough, right? Let me explain to you why this is really valuable for you to finish all these antibiotics. Let me describe to you why it's really important that, these antibiotics don't go to your friend or anything like that. In fact, let me see your friend instead so that I can get them the correct antibiotics. And then it's also just making sure that you are dropping all the barriers that you possibly can for the folks that you're serving in terms of adhering to those antibiotics. So, will a pill box help you? Can I help you with that? Is it going to be the case where you're possibly getting displaced here shortly? And so what can I do to help you? I've been known to buy those little passport holders off Amazon and then tuck a pill box into it. And my patients are like, this is awesome, right? Because it stays under their shirt, it's on them, and they're able to and also it's like, it's right there. So they remember to kind of take their meds. So lots of those sort of little tricks, but also really, really asking my patients, like, what's going to be easy? It's that motivational interview. What's going to be easy about taking these antibiotics? What's going to be hard about taking these antibiotics? And how can I help you? So I think that is more of where I'm focusing that antibiotic stewardship concept.
That's beautiful. I love the passport holder with the with the pill bottle.
It has been a game changer, and also outside of just antibiotics, but Suboxone and other things. I have had so much good outcomes with using that, and it's super cheap on Amazon, costs nothing. So
something that we struggle with in my program is the patient that will refuse to go to the emergency room for an infection that really needs IV therapy. What do you do?
Yeah. So first, I ask a lot of questions. So what will be tough about going to the ER? Because we know that there's a lot of things, but our patients have so many competing survival priorities, and I need to know which ones are going to be the ones that are really going to make it difficult for you to go in. So is this going to be an instance of you're very concerned about withdrawing there and you maybe need an advocate, and I can go and advocate on your behalf? Maybe I can see if there is an addiction med team that can consult out of the ED. What can I do to help you there? Is it going to be your belongings? Is it something that comes down to that? And, I was just in a small group with a bunch of folks who talked about identifying some of their local partners who were able to store belongings for people while they went into the hospital. And so just trying to figure out what are your barriers and how can I help you drop those? Also validation, right? Going to the hospital is horrible. It's awful for anybody. And so I never sit there and disinvalidate their distaste or their desire to want to stay where they are. And I think once you can kind of validate, then it lets them sort of be seen a little bit better, and you can kind of get more to that deeper conversation. And then what I'll do is maybe see if there's a plan later on, right? I know I would love for you to go in right now, but is there a chance maybe you could go tomorrow or the day after, because that's going to be better than nothing. And if all else fails, and actually I was telling everybody, I was taking care of a gentleman who had an external fixator on his leg for 1.5 years. And that was when I found him. And so those are going to be sort of those big, clunky halos that are on people's legs. So by the time I found him at 1.5 years, he had just horrible infection that was visible. It took me 1.5 months, but I visited with him all the time. My outreach team met with him all the time. And we just kept talking to him and building that trust and coming up with a plan. I also told him, I said, look, if this is going to take a while, what are we working towards and how can I help us get there? So we slowly checked each box to really help him, so that he was going to feel like, first of all, he had autonomy, like he was building the plan himself. And he was on board with that. And so by the time we checked all the boxes, I remember looking at him and being like, the boxes are all checked. What do you think? And he was like, okay. And you went in, and we got it all, all taken care of. And so it's really persistence, and it's really following up, and it's really being non-judgmental and gaining trust. And then if all else fails and it looks really bad and you're really concerned, we have Rocephin. I will oftentimes use Rocephin. And I'm not sure if I'm allowed to name other medications on this, but I'm really working on trying to
use generic names.
I'm trying to figure out how we can get daptomycin as an option for.
Is that dalbavancin?
Yeah, dalbavancin. Sorry.
Yeah.
So sorry, I didn't give you the generic, but yeah. So that is something I would love to see. I actually got to help with a study at one of our hospitals with that, and just had fantastic outcomes for patients, and they loved it. So 30-minute infusion, and I think we can do this. So I think you and I have had some, yeah.
We're going to two more questions on that.
Cool.
First, the ceftriaxone, 1 gram.
Yes, a gram.
1 gram IM intramuscular daily.
Yes.
Okay.
Yep.
That's what you're doing. Okay. Let's bring our audience in on what we're talking about. When we send someone to the hospital and they need IV antibiotics, they're getting their daily vancomycin for 10 days. So they need to be hospitalized during that time. The medication we're talking about, dalbavancin, has a half-life of 14.2 days, and it's a half-hour infusion, IV infusion. So I'm curious, where is Los Angeles on developing a protocol and using that?
We are being very thoughtful. We're trying to find other folks that might have a protocol, and so far I don't think we've come up with that. You and I have talked about your protocol, and I'll turn the tables on you.
Well, okay. The protocol is to rely on the experts.
Sure.
So we have a DNP, FNP, infectious disease specialist who is very helpful to us and will see our patients routinely, and we let her order the dalbavancin, and then we go to the IV infusion center with our patients to do it. We have not done it on the street.
Does she think it's doable on the street?
I was going to respond to the question I thought you were going to ask. She loves dalbavancin.
Yes.
Okay. So it's so useful for our population in terms of the osteomyelitis, even the endocarditis. So it's really could be a lifesaver. Mm-hmm. So she's a big fan. I think she is in favor of us offering it on the street, but those protocols, you just, when we talk about antibiotic stewardship, you don't want to get into a situation where you're like, oh, everybody needs dalbavancin. You want to save it for where you want to target your treatment therapy so that it's highly effective and not going to create resistance. So we're working on that.
I think that this might be sort of a consensus sort of topic where we might need to really consult with lots and lots of specialists on it, especially folks who are using it like the folks that you're working with. But I do think that this is something that is doable, but I agree with you. We have to be incredibly thoughtful about patient selection for it. Because you're right, it is such an important tool in our toolkit. And if we lose that for our patient population, it will be really, really terrible.
Yeah. So this edition of our podcast has been more clinically focused than most, which is great and appropriate. And I've really enjoyed our conversation. I'm going to ask you 2 final questions. First of which is, if you could give advice to our listenership of something they could do to make the world a better place, what would it be?
Yeah, I think one of the key things, and this is really integral to street medicine, is to slow down and see people for who they are, right? So often we are quick to make assumptions. We are quick to feel like we absolutely know somebody, and we just don't. And so whether that is, taking in nonverbal cues or just asking more questions about people, it's wonderful for them, but it's wonderful for you. And then it's wonderful for humanity. So see people where they are, see people for who they are. And that's everyone. That's our patient population, and then that's your family, that's your friends, that's everyone.
Thank you for that. We tend to go to taxonomy immediately with meeting a new person of where do they fit into my previous experience, and to have a fresh eyes, fresh look, to withhold judgment, that's so vitally important. So thank you for sharing that piece of wisdom. The last question is, how can folks connect with you and your program and support you, and what can people do?
Yeah, so In terms of connecting to our program, we do have a landing page, USC Street Medicine, and we actually put on lots of different trainings around California. So we are open arms. There's no cost to our trainings. We want it to be available to absolutely everybody, and there's CME for the clinical-minded folks. And so this is something where it's also a community building opportunity, and we love to bring people in. So open arms, no matter where you are in your street medicine journey. If you're thinking about it, if you're kind of critical of it and you're interested in hearing more, like, we want to hear from everybody. So we are open arms for all of that. And then in terms of just supporting us and what we do, I think that the thing that comes to the top of my mind is just to be kind to the folks that we get to serve. Because, one of the things I think about whenever I come across a new patient is I'm a mom and I'm a new mom. And I think so often about the delivery room where that person was born. And delivery rooms are very big celebration places, right? These are places where people are so celebratory. And somebody looked down at everybody being born and said, I wonder who you're going to be, right? And there was so much hope and there was so much love. And I always try to bring exactly that to the person where they are now, because I think so oftentimes they haven't been brought that. So try that. Try it on, because it's a really, really great way to get to help support the people that we're taking care of.
That's powerful. That's powerful. Kate, it has been a joy and a pleasure to talk with you. Thank you so much for your appearance here on Streetside, and look forward to staying in communication.
Oh, thanks for having me.
Oh, you're welcome.
The opinions expressed in this podcast are those of the individuals included and are not representative of the opinions of the Street Medicine Institute or the Street Medicine Institute Student Coalition. Do not use this podcast as medical advice, and instead see your own provider for medical care.